Welcome to the latest edition of the College of American Pathologists Capcast. I'm Becca Battisfor, Content Specialist with the CAP. In this episode, Dr. Joe Sirintrapun will be talking with Dr. Jochen Lennerz about his experience with implementing digital pathology. Before we get into the questions, let's learn more about our guests. Dr. Sirintrapun, would you like to introduce yourself?
Oh, thanks, Becca. So I'm Joe Sirintrapun, and I'm the Director of Pathology Informatics here at Memorial Sloan Kettering Cancer Center in New York City. I've been around for a little bit, been involved with CAP on the Digital and Computational Pathology Committee. I'm actually leading or co-leading the implementation work group, and just happy to be here.
Great. And Dr. Lennerz?
Hi, my name is Joe Lennerz. I'm a pathologist. I work at the Massachusetts General Hospital. I direct the molecular lab and work in the Center for Integrated Diagnostics, a CAP member and part of the newly introduced CIPI Council. Thank you.
Great. And thank you both for joining the podcast today. Dr. Sirintrapun, I'll let you take it from here.
Thanks, Becca. So this is going to be a fun one because you can never have enough Joes. So you have myself and you have Joe on the other side. But so Joe, I'm going to ask you some questions that I pretty much ask all the guests, but we'll start with the first one here. What were your challenges in getting your institutional leaders in laboratory degree to digital pathology implementation?
That's a very good question. So I think the first part is, of course, leadership buy-in usually means you have to have good arguments. To have good arguments, you need to know what you try to accomplish with it. So I would say the first part is that you need to distinguish whether you work or whether you implement digital pathology for, let's say, research, for education, or for clinical workflows. And I think the arguments you need to bring for each one follow completely different paradigms. If you have a research impetus, you want to probably see or tie it to publications or funding mechanisms that would cover for the cost, and then you can offer it as a service or a core laboratory. When you do it for education, I think, courses, CME, and, maybe your institutional approach is probably slightly different, but, you can do slide conferences or, there's like a portability associated with that. And then, of course, probably the most relevant and most challenging currently is clinical implementation. So you have to make certain promises and the arguments around reimbursement that function for other let's say new tests or technologies may not be as applicable for that. Now, once you have your arguments ready, I think some of the challenges that you face is related to funding and value propositions, not only that they differ drastically, but different people, of course, with their individual interests might be more amenable to one versus the other. And then, of course, if you have other components related to that, in, let's say, in the clinical space, you have to figure out what the validation would cost, what other aspects you need there. So simply put, what challenges I personally faced is figuring out which one is the best initial step to get your feet wet. So we started definitely more on the educational and research side, because it is, the funding can be obtained through regular mechanisms. And then having that experience makes it a lot easier to talk about, other clinical implementations. I think probably the biggest challenge from a clinical rollout is you have to be accountable for it, meaning it's one thing to ask, leadership about certain components and funding and, let's say support. But I believe the most important part is then if you want to own it and if you want to run it, you have to be accountable for it. So you have to, have good, SOPs, validations, etc. So in other words, the one word answer is you have to have really good arguments.
No, that's great. And I really appreciate you going through all the different, because all these arguments are individual and everybody has to sort of, as an institution, sort of has to take a look introspectively about which argument really works for them. So it's really great that you were able to share that. So maybe along the same lines, what pushback did you face in terms of getting your colleagues, to accept digital, as it was proposed?
Over the years, yes. I remember one particular attending, and I think it's still echoing to this day. He came in and said, "Oh, what's that? That's like as useless as the moon landing. And, I was just thinking like, all right, good. That's an interesting opinion to have, and, sometimes, the pushback comes from out of nowhere, where you think that some people are extremely technophile and like they want all the new stuff. But then when it comes to, oh, you want me to do this for sign out? Oh, no. So I think it's mostly a surprise in a way sometimes. But I think by now, most people have some experience with digital pathology. So I think currently it's more those that are absolutely married to their microscope. They love it and they find it okay. And the most pushback, I think, is if you start interfering with their day-to-day practice and with their time. And I think some really high throughput surgical pathologists, they cannot tolerate if you change the outline of the report, and it's all optimized for efficiency. So I think a little bit of change management is probably helping with that. And maybe the key element from the pushback that I experienced is the real high throughput surgical pathology disciplines, whether that's really possible to completely digitize. I think that's probably the area where I see most pushback currently.
Yeah, I'm at, along the same lines. I mean, what advice would you give yourself if you had to do this over, to get a redo?
Oh, that's a good question. I would say I would just do it. That's the quick answer. Like, not hesitate too long, not overthink the various different things. Settings differ, of course. I've set or helped set up a digital pathology in 3 different institutions, and the settings were completely different. The use cases differ, and each individual decision can be pondered, met about, and having like hundreds of meetings about, for example, which scanner to buy. And it's each individual decision is not as important as starting it. Just getting started. Sometimes it's not worth discussing whether it's a 5, a 10, a 50, or a 500 slide scanner. It's just important to have one. I'm sure there have been meetings about which fax machine to buy. And I think those were probably extremely meaningful meetings at the time. But, at some point, it's just like, let's just do it.
I really like that. I mean, don't let analysis paralysis really, take the better of you. Yeah. So I really like that spirit of just go and just dive right in. I mean, you can't learn swimming unless you're just in there in the pool. So, I was wondering if I was going to ask you this, but what are your wins so far? With it, you mentioned you implemented for education and other things. What can you take away in terms of some of the victories that you've had?
So I think one victory is, of course, that we have access to files. And I used to say that digital pathology, or the histology, is actually the one missing image from the medical record. Now, while the images are not yet in the medical record, I think we have access to the files, and that opens up a gigantic, set of benefits that is hard to capture or enumerate. But if you want to look at a prior case, you can search it, find it, open it. It takes, 20 seconds. That is extremely convenient, and you don't need to pause, put it on your list, or request it, wait to get the slides, to then rethink why you wanted the case to re-review. I just wanted to compare morphology. So I think those let's call it tangible or intangible benefits are extremely prevalent. So I learned to recognize that is actually one of the key things. So we rolled out digital pathology, went completely digital just shy before the start of the pandemic in our molecular lab, where it's arguably a unique setting where you have typically one representative slide for an entire tumor. But then having that morphology and being able to correlate molecular findings with morphology is just a very educational and scientific endeavor, but it's there. Now, the other win is that once you start doing this in some systematic capacity, in one of the institutions, we had the rule of putting a sticker on the diagnostic slide, for example, of consult cases. And then those slides were scanned individually, but you had a permanent record. That doesn't sound like it's that complicated. But over the years, you built a database. You have, these files available for all the use cases that we discussed earlier. So I think we might need to realize that digital pathology is not the one thing that will change everything, or the one use case that is suddenly unlocking this as if some sort of knot opens up and then everyone goes digital. It might be that this is just like, back in the 70s and 80s, the automatic cover slipper. It's just a thing that adds value on multiple levels, but dissecting it out for like the one win might not be possible. So a lot of diverse wins, but not like one specific one. But I think the ability to work remotely shouldn't be underestimated. I think that's a huge, win that we at least booked in the molecular side.
I appreciate that too, because and I've brought this up in several other interviews with other folks too. This archival was very big, and I always bring up the feeling, when I'm on Frozen's. And in fact, I was on Frozen's yesterday. The ability to pull something without actually having to request from the slot file room, it's just priceless. There's so many add-ons. You don't have to think about it, to be able to compare at the instantaneous of, at the end of your fingertips, that feeling. And I can tell you that if we were to take that away, like, oh, you know what? Sorry, scanners. Sorry. I think we would revolt. I'm positive we will revolt. Not just me, like the entire department. And that feeling is something else, So, and the ability to do remote, that was very big during the pandemic. Those, I still have my little home office. So those are some of the big wins also. So your wins sound very similar to ours as well. So let me ask you a question that's a little bit different from some other folks I've had on the podcast, but and you know how much I love participating, but the PIcc Alliance, tell me a little bit about that. Maybe just tell us a little bit about this story behind, basically the organization that you've founded and all that.
Sure. Thank you for asking that. It's it's very near and dear to my heart. So maybe just as sort of the beginning is basically through chance and circumstance. I was the PI on the first instrument precision study of a scanner, a whole slide scanning system, and realized that the FDA thinks about devices quite different from, let's call it, the practicing pathologist. And at first it was sort of a gap, and I just thought, what are they talking about? And over the years, I, through many different people that I was exposed to, I learned to see it slightly different. And the field is called regulatory science, which is the science about regulation. And at first I thought, how can there be science about regulation? That doesn't make sense, because regulation is like human made. But then, after a while, it dawned on me that, well, if there's a new technology, there cannot be regulation around it because it didn't exist. Otherwise, it wouldn't be new. So then the question is, well, how do you apply the scientific method to inform regulatory decisions or regulatory guidance, or, the field itself became suddenly very interesting to me. So one of the people that I was exposed to was Esther Abels, at the time, a regulatory person in one of the major companies. And through her, I met Brandon Gallis, who's on the FDA side, a scientist within the FDA. And the three of us conceptualized sort of like, how could we tackle this field that is apparently, or at least it seemed, almost completely ignored by many of the other societies. And, we said, well, this may need some initiative behind it. And, it was, it resonated really well with, I think, a broad range of stakeholders, CAP, the Digital Pathology Association, the Association for Pathology Informatics, and you name them. Currently, over the years, once we started, we realized that there are so many different stakeholders. So in very brief, a regulatory science initiative is just like any other collaboration, an interest group. But what's different with PIcc or the Pathology Innovation Collaborative Community is that this grassroots movement at some point became a little more formal because the FDA has a certain program that's called Collaborative Communities, which has to fulfill certain criteria. Won't cover that, but just to outline a few is the vision, and a charter has to be drafted, and it should be open to all, and it shouldn't be restricted. So there's no membership fee, there's no talking about pricing, or antitrust monitoring has to happen. So there's a couple of rules around it, but the main point is it should be a community for the community, meaning everything is open, everything is shared. And the interesting part is it creates a platform to ask all kinds of interesting questions. Now, Joe, I know you post some fascinating questions over the years, but it is almost like a little bit of a treasure chest where you put all the things that don't fit into other, the typical rubrics. And I thought that was something fascinating. By now, we have about 600 members, so a lot of people receive emails, many join the monthly steering committees, and it is really sort of a community where you can interact across the various stakeholders, but with FDA participation. Notably, the FDA or the agency participates actively, and they speak also on their own behalf. Now that is something very unique, because normally the FDA is not really informing anything in terms of like outside the realm of a specific submission. And even within that, it's usually confidential. And, just hearing what the reviewers or the scientists behind that curtain think about certain topics, I think is probably to some of them liberating to hear and run some of their ideas by us, meaning the field, and vice versa. So long story short, it's an interest community that enables something that wasn't there before. So it's, irrespective of being public or private. And, if you haven't seen it, pathologyinnovationcc.org, and yeah, just check it out.
Yeah, we should put that in a link somewhere if we can. But let me add a couple things to that, being, on this.
Yeah.
If you told me 10 years ago that regulatory, even the science of it, that, I would actually want to participate, I'll be like, what the heck? Because nobody thinks of regulation as being fun. But I can tell you, being part of PIcc, you make regulation fun. It actually makes your mind, it bends your mind, it makes you think, it stretches it. It gets you outside your bubble, because, it's not just academic folks, it's everybody there. You got regulators, you got the FDA, you got government, you got vendors, you got everybody on there. So you're outside a bubble. Makes you really think. It not only tackles digital pathology, but it tackles genomics. So, it's a great place to even have, who would have thought regulatory science can be fun and thought-provoking, but somehow you pulled it off. And that's why I said it's pretty unique. It's pretty unique. So
thank you.
That was a nice tangent, but
I couldn't do it without, the help of many folks like you. Ulla Green is amazing. We try to be as transparent as possible. And it is very interesting because we also ask from the people who participate to be active, which I think is, in some settings or meetings, it's more that you passively digest things. But, I think the ability to ask people to actively contribute, and they want to contribute, they want to actively provide information, for example, to the agency, I think is fairly cool. So it's also a lot of fun to make it fun.
Yeah, and you help digest things for me. I forgot to mention that too. Sometimes when it gets very wonky and complicated, I sort of go to you and get stuff in digestible bits. So
thank you.
So let me ask you something. Let's get a little, I might know this story, but what was your first personal experience with digital pathology?
Oh, well, Mike Isaacs at WashU.
I thought you'd mention him.
Oh no, it's like, a great friend and collaborator over the years. So at some point I remember that, I was as a resident at the time, and I ran into his office, and he was sort of like, what's going on? Why is a resident coming to me? And, he's the IT director. And, I was like immediately sort of like hooked with this idea, like, why aren't the slides scanned? Well, we should do that. And, then at the time, I think it was 2007, we had a North Campus, and the North Campus didn't have all the offices. It was just renovated, and it just so happened that I was the molecular fellow and I didn't have a microscope. So, but we had a scanner, and so then I switched over to just be fully digital for like at least the slides that I needed to review. So, and it was very interesting when I went to GI fellowship, I had to switch back to the microscope, and it took a few weeks to get back into like using the microscope. And so definitely big props to Mike Isaacs, who also, I remember we worked for a long time to get our LIMS system to be able to open the slides, and that was like a big breakthrough to be able to have that. So yeah, so it's been a few years.
I figured you mentioned Mike. So yeah, so we all have kind of a mutual network connection. And also that was probably the time when we probably met. We're all from around the St. Louis area anyway, so it's a small world. But
absolutely.
Well, let me ask you the last part. So I'm going to ask you to put a crystal ball, break out the crystal ball. Where do you see digital pathology heading in the next 5 to 10 years?
That is a very, very speculative thing to say, but so I think there will be a lot of things happening over the next 5 years. First of all, I think a change that is probably coming, and it's a harsh wind, is that for the first time, a technology is not entirely just owned by pathologists. So many of the other innovations, I would say, were internal developments. But I believe there's a new sort of vector in the equation, and that's an external force. People will want our data, and in particular, the histology. It's images. A lot of people know that one of the big applications of AI is image analysis. And, in radiology, the field is booming, and a lot of the ground truth is actually in our slides. So I believe that we have so far, I don't want to use the word enjoyed, but that comes to mind, the element of internal development for all of our progress. But I believe that there is now a tendency in the field that we will face an external force. And I would go as far as saying that over the next 5 years, we will have to adopt to that, meaning that outside entities will come with, all risks and benefits and say, look, we want this. And then I either be ready or, you be not actively influencing that. So, and in addition to that, I believe what will happen in parallel is that for selected, let's call it care pathways for specific applications, digital pathology will probably be more amenable than others. So a lot of people think that, for example, mutation prediction from H&E slides will enable a diverse set of populations. And I mean with that patients, but I also mean settings in terms of healthcare settings, the ability to pre-screen, let's say, certain cases. Of course, there's like regulatory aspects to that. But so I believe that the progress will diversify, and it will come from all ends and all directions. I do not think that has happened like that in pathology. Usually we square things off and we box it into specific functional modules. But I believe this will touch us sort of like in the middle of, our workflow, which is sort of where the microscope sits. In terms of like other sort of trends that I can see or perceive is, I believe data sharing will be absolutely critical. It will, as you know, CMS just released the guidance that we are allowed to continue, exercising what we've done during the pandemic. But what that will lead to is basically more remote work, more second looks, more effectively image and data sharing that will be enabled. So we need to have really good policies around that. We need to come up with sort of the regulation around slide retention, digital slide retention, and then, overcoming some of the key challenges related to, diverse patient population, minorities, etc. We really need to harvest the metadata as well. So I believe pathology will undergo a complete data revolution. The beautiful thing that we always say, like our LIMS systems look like in the 80s, that will be unacceptable. I think it will morph into a data-driven field, and the digitization of slide is one component of that. But with, let's call it the data structures that we have in pathology and the extreme high value and reliability of pathology, I believe is not even, people are not quite aware yet, but that will in my opinion, definitely happen and probably change the face of pathology quite a bit.
That is quite a remarkable answer. A lot of that stuff I wasn't even expecting or wasn't even in my radar. So I really appreciate that. I'm going to drill down in some of the points you mentioned. In some ways, it reminds me, there's an old saying, I think, in the consumer industry, like if you don't really, when you're dealing with AI, if you don't really know what they're trying to sell you, you're most likely the product. And I think when you mentioned that the third party and these external ones, it almost makes it sound like pathology might be the product, because they're generating so many data, not just like pathologists, but the outputs or results, the other interpretations. That's all part of the product, and people will find it valuable. They will want it now that it's digitized. But that can be seen possibly negatively. But one thing you mentioned in the second part, you said that legacy technologies won't suffice. One of the issues is that, who's going to pay and build all these technologies? It might be the external forces, because they see the value of the product itself. You might see that the LISs that we had before just aren't capable. So these third parties are going to say, you know what, to capture data better, to be able to allow us as the product to be a better product, we need to have better systems out there. And that part, I think, is very profound. I didn't think of that, but I think that would be very interesting, because that, it's a business case in itself. Yeah, there might be the product, but as a byproduct, you can see a lot of massive advancements and improvement in technology around the practice of pathology. For pathology to be a better product, we must have everything around it be better. And that might be the onus for that. So I think that's a very fascinating philosophical answer. So I appreciate that. Did I kind of sum it up, maybe what you're thinking, or anything to add?
Yeah, no, I fully agree. I think that the part that is, and I know you've been part of that conceptual study that's capturing what I believe people consider diagnostic quality, is that it's not just a test, right? A microscopic review is not an assay, it's an interpretation, but that's the test level. And then we have the procedure level around that, which is, entailing in the future the scanner and AI tools, but it's the procedural layer surrounding that. And then the outside layer around all the procedures is what an individual, let's call it department, division, or pathology practice, offers in terms of service. So there's test, procedure, and service. And all the three things have to be in unison to make something a high quality product, to use your analogy. So I think you're spot on. But I don't believe that most pathologists consider themselves a product, or that they deliver a service that has to have a certain external facing marketing aspect, and it has to be, digestible, or it has to be interoperable. But that will be a force in the field of medicine pointing at pathology to say, well, maybe not everyone can read an X-ray or a CT scan, but the data is available in the medical record. At some point, there will be a group that says, look, we're going to put our H&E slides in the medical record, even if it's just that you can quickly pull up something during a tumor board. I mean, the interpretation of a CT scan is still the domain of radiologists, despite the image as a service being available in the medical record. So I foresee what you just said. I didn't think about it as a product, so that's a great analogy. But we're all service providers, and customer service, in terms of like being a good collaborator for our clinical colleagues, and exercising what is our clinical practice, is absolute key.
Yeah, I mean, it wasn't my intent, but I can see this being a very provocative thought experiment with this discussion. But it's something that I would have never thought of, and I appreciate you answering that question. That was a very unique perspective. So with that in mind, Becca, I guess I'll turn it back to you.
Great. I think we covered the past, present, and future of digital pathology. So I want to thank you both for joining again to talk about your experiences. And I want to thank you all for listening to this CAPcast. To learn more about digital pathology, the Digital and Computational Pathology Committee has a great resource center on the CAP's website. The link to that will be in the episode description. And for more information about the CAP, visit cap.org.